Welcome to NeuroNights. My name is Kedar Hiremath, and I am here talking with Christine Koterba and Nathan Rosenberg from Nationwide Children's Hospital about pediatric brain injury. First, I want to get to know both of you and what you do. So let's start with Christine. If you want to tell us a little bit about your specialty, your training.
Yeah.
What got you into this?
Yeah. So like you said, I'm Christine Koterba. I am a pediatric neuropsychologist at Nationwide Children's Hospital and an associate professor of pediatrics at The Ohio State University. And I kind of split my time between inpatient settings where I get to work with kids with brain injuries of all different severities, and I get to follow them all the way through their hospital course, through inpatient rehabilitation for those that need it. And then I get to work with them in outpatient settings as well. So I get to see them sometimes months to years after their injury and get to help them kind of navigate that process. I also am involved in a lot of different pediatric brain injury research, and I am primarily interested in looking at outcomes, predictors of outcomes, and ways that we can kind of help improve those outcomes across that injury journey for kids. At the community level, I also am involved with the Brain Injury Association of Ohio, and I've been on the board for about the past 10 years, and I am currently one of the vice presidents of the association, and am involved in a soon-to-be-started return-to-school initiative for kids with brain injury. So thanks for having me.
Awesome. Nathan, what about yourself?
I'm a pediatric rehabilitation physician at Nationwide Children's. I get to work with Chrissy a lot. And so that training is in the function of kids. And so we focus on, in many ways of how kids work, doing things they love to do. And I like to boil it down to that. And that's the clinical aspect of it, which a lot of that involves traumatic brain injury. So we get involved quite early when children have traumatic brain injuries, and we hang on. We hang around. We're around a resource for a very long time. Clinically, that's a lot of what I do in the hospital as a consultation service that we do. And then in the outpatient world, we also care for folks with brain injury there. On the educational side and on the academic side, a lot of my work is done in shared decision-making, in doing things, the clinical world where families feel empowered and there's a lot of trust there. And also more recently in a topic called time toxicity and measuring and discussing the time costs there. In terms of my academic affiliation, similar to that of Chrissy with Ohio State, it's the Department of Physical Medicine and Rehab. I'm an associate professor right now.
Well, it sounds like you wear a lot of different hats as you do this work, and there's a lot of different perspectives to think about when it comes to, let's say brain injury in kids writ large. So let's just talk about what that is, right? So, if you go and you look up, pediatric brain injury, you're going to see a lot of sports concussion stuff. We think about kids falling. We think about, young drivers, risk-taking, things like that happen in early life. But then you look at the global scale and, this is a pretty prevalent and high incidence injury type, leads to a lot of death and disability. How do you kind of help people contextualize some of this data that says pediatric brain injury is something to consider and be concerned about?
In our world, I think it's safe to say that it's common because we're always doing it. There's within the hospital, we're always caring for somebody with a new brain injury. And I have to pull some data to be 100% sure of that, but I think it's pretty true. And so you can look at the demographics there and say that it's either common or it's not. And I think that when I speak for my own world, it's common because it's always there. As it relates to society, I think that we can generally find, most people, if they're in a community, can generally find somebody that they know or somebody that they know that has had a moderate or severe traumatic brain injury as a child. And so in that world, it seems common enough. And at the same time, because it's so heterogeneous, because there's such variability in the kinds of brain injuries that we see, I also make sure every time I walk into a room to say, this is the one. This is the only one right now in this room. And it's a clean slate. And so you can say it's either really prevalent or it's not really prevalent. But in fact, this is the only one that we're dealing with right now.
Yeah, and I think along those lines, a lot of what we're doing is kind of finding this balance. and I think working on both the clinical side and the community advocacy side, I'm trying to strike this balance of giving reassurance to some patients and families that, hey, yes, you had this injury, but it wasn't that severe and you're going to recover and you're going to do better. Or in some cases, with a single uncomplicated concussion, we usually see a really favorable recovery. And so, there's kind of mixed consensus or mixed information, I think, out there about injuries like concussion that are much more prevalent. In a lot of cases, those kids do really well. But then on the flip side, I'm also trying to increase awareness more at the community level of, hey, these kids are out there. Just like Nathan was saying, I think if in any community, if you look hard enough, you're going to find someone who has had a very severe injury at some point. And so increasing that community awareness that these kids are out there and we need to do something to help support them. So even if it is a smaller number with those more severe injuries, those are the kids that need the most help and that we really need to raise awareness for. So I think it really is kind of striking that balance. And it's hard for people like us that work in acute trauma, pediatric healthcare, because we're seeing the 1 in a million cases. But then, how do we go and take that back and kind of help to balance that narrative for people who don't work in those settings?
Well, it makes sense. In some sense, every brain injury is as unique as the person, right? We constantly hear that refrain. And then when you look at the data, they're not all the same, right? And so there's this spectrum of injury. And we also have an interesting classification system of mild, moderate, and severe, which is not always the best way to approach things. From a symptom standpoint, from decision-making that the family has to do, impacts in their life, what does that look like for a typical person, or what could that look like for anybody?
Yeah, I think it really could be broken down based on the stage that they're at following their injury and the types of decisions that family might be facing and what the patient is coming in with. Really, really early on, some of those decisions might be kind of what is our quality of life that we want for our child? What do we want their future to look like? And as you go through that recovery course and maybe as things are looking better from a medical standpoint, this is a child who maybe was very sick, very severely injured. Now they're starting to get a little bit more stable. When we get out to those weeks to months, now we're starting to decide what are those next steps that we want to take in terms of, rehab or therapies. And I'll hand it over to Nathan here because that's a big thing that he is navigating with families, especially in the inpatient setting.
I feel like the joy of our system at Nationwide Children's is that we get involved on day 0, day 1. We're in there right away. And it's like, well, how much rehab are you going to do when we're trying to keep a child alive a lot of times? And there's a lot. There is a lot. It's not physical on hands there. It's more of this person has an identity. And there are a lot of people that are, and I'm so thankful for them, in that first phase of let's stay alive. And they talk to parents, it's still a let's stay alive phase of all the numbers and the intracranial pressure and all those things that get managed outside of our world a bit. And then there's this child's identity behind there to say, okay, pretty soon we're going to be looking at just that. At what makes this person tick, what's valuable to this person, what do we want, what do we know about them, and parents will, it's in those moments, share, parents, caregivers, family, will share some very, very vulnerable things about their fears and the situations, and we are the people, a lot commonly throughout that recovery phase, that they'll be leaning into. And so that first day, that second day where you come in and ask those questions about the human, it's a chance to build trust, to say, okay, these are the folks that are going to help you on this road. They're going to help pave the road, or at least describe where that road's going to go. And so there's this early trust building phase that I find really valuable, and engendering trust in the healthcare system, which a lot of people just haven't had to ever touch.
And I think one of the things, and Nathan and I talk about this a lot, is there's a lot of subjectivity that comes into this. And, I think I can say this, that if you and I were to be in the same exact situation with dealing with one of our own kids, I think we might make different decisions, personally based. You can say it without hesitating, and so I think that it's fun when we get to work together, because I think we get to bring that kind of vulnerability about our own selves and say, this is, here's what I these are the pros that I see with maybe this path, maybe going towards more rehab, more therapies, more time with the medical system. And then Nathan might bring in that alternative perspective and say, here's the benefit to maybe spending less that time here and more time at home. And then we both can say, we don't know what is going to be best. We don't have the research that says this is better than that. And that's where, you really, as a family, I think as we're trying to gain their trust, we're also trusting them to make the decision that is best for them and their family. And we have families sometimes where they might say, oh, I don't want Dr. Rosenberg to be mad at me, or I don't want Dr. Koterba to be mad at me, because I think they can inherently tell probably what we would do.
Yeah, this is correct.
But it's not about us. It's about supporting the family and making the decision, giving them everything that we know, while also acknowledging there's a lot we don't know.
Well, this resonates with me a lot, right? As we were walking in today, we were all talking about our kids and going to school and things like that. So, fairly similar mindsets in being a parent, but then every family is different, every situation is different, every kid's different. And this idea of, is there a right way to do it? As a parent, you want to go to the doctor and feel like, okay, I've been doing things right. I've been making good decisions. And in this, there's so much uncertainty. And individuality that, is the approach just, let's give you the information that you need to make a good choice? Are there right things to do that are typically going to be right for most families? And if so, what would those be?
Because there is, in medicine, there's the standard of care where people say, okay, if we study 100 people, this is the best thing for 68 of them or whatever, right? And the humility in providers there is that there's 32 other ones. And that's where shared decision-making comes in, because you don't have all the information to figure out which one's which, because family values come in here, and personal values and resources and goals of care. And so a lot of times I find myself going into a room and saying, this seems like the most likely treatment option that's going to get the best outcome with the information that I have. And I think that's where provider humility comes in, where you go in the room and you have the conversation with a plan to make a shared decision. You say, okay, these are our 4 potential choices from right here. The New England Journal might say that this is exactly what we should be doing. And then there's 3 other choices. Tell me where you are. Tell me what your goals are. Tell me everything else. Put this whole picture together, and we often find we're somewhere else. Whereas the paternalistic approach would be to go in there and say, here is the standard of care based on this study, and not ask the questions, and not empower families to make decisions for their kids, as opposed to just making them for them based on what the standard of care is.
Could you give me an example of something like that? Like how some concern that a family member might have, where they have to kind of work that out.
Yeah, so I think a good example is a medication called amantadine.
Okay.
So amantadine developed as an influenza drug initially, and there's a New England Journal study. Maybe that's the one I was thinking of, suggesting that amantadine improves arousal and some functional components with data while it's being used. So you give somebody amantadine as they're recovering from brain injury, and their function improves some. And maybe beyond the scope of this conversation is how much is some, right? Because it's not a huge amount, in my opinion. That's an opinion. And the conversation is, okay, here's a drug. Your child's waking up. This could help you wake up more, potentially, or not. It has a side effect of vomiting if you use too much. And that's not fun when you've been recently acutely ill. And it's really hard to tell if your child is waking up because your child is waking up or because we're giving them amantadine.
Yeah.
And so a study, which was the best data, it's an adult study too, we're giving it to kids, would suggest that it does help kids do more. And if you ask families about it and talk to families about it, sometimes what you get is them saying, this isn't for us. And if you ask, and in the case of amantadine, it's nice, and Chrissy and I both do this, and I'd be interested in your perspective on it too. We talk about it before we start it, and oftentimes say, here's the article. It's pretty palatable. It's a pretty palatable article. Let's make this decision together. And I'm curious to see, because you have your side of the conversation too.
Yeah, when I think a lot of times too, like what is nice about the way that we get to work together is I feel like you can kind of lay this theme, you kind of set up the stage for things and have that initial discussion, and then we can talk, and then I can go back in and then talk with the family some more and really kind of see what they want to do and answer any remaining questions that they might have or discuss things further. And a lot of times, I think in addition to leaning on the research, we're leaning on our clinical experience and what we've seen with similar patients. And that's what families ask a lot. Like, have you had a patient like this where you've tried this and what has it been like? And I think that with something like amantadine, usually it is pretty well tolerated. And if it's not, it can be stopped quickly. And to my knowledge, are like adverse long-term impacts that we know of. So I think that really helps families with making that decision. And so those will be, discussions that we'll be having, that this is one thing that could help. And one of the things that I do as a neuropsychologist is when we're looking at patients that are at this very low level of functioning, when they're just starting to hopefully wake up, we can look at their responsiveness and see how they're responding after taking a medication like that. So I think that can be helpful for families too, to know, okay, we're going to be measuring this to see what their responding looks like. But if that's something that they say, this isn't for us, we've got too many medications, we don't want to pursue this, then it's like, okay, we've presented this, we've talked through the pros and cons, this is what you're most comfortable with, so now let's move on kind of to the next thing.
So if I think about this, there's a couple elements in here for maybe some follow-on questions. So the first one is, if I'm a family member of a child who's had a brain injury and that injury turns out to be more moderate and severe, first off, I should be expecting that I don't know what's going to happen. Mm-hmm. And in some sense, we all don't know what's going to happen. And the best plan of action is really just to communicate and really think through each step, take it for what it is, learn and adjust as we go. Mm-hmm. Does that sound right?
Yes.
Yeah. And I think, what's so interesting with brain injury is there's some parts of it that are fairly predictable. And even though every kid is different and every brain injury is different, we know that there is a predictable course of recovery. Now, we don't know how long it will take for somebody to recover. We don't know how much they'll recover. But we do know that patients tend to go through certain stages of recovery. And so I often think of our role is I almost feel like I'm watching a movie with a family, and I've seen this movie a million times. I've seen the movie. I know the twists and turns that are coming up. I know that cliffhanger. And they have no idea because they've never seen it. Mm-hmm. And what I love about what we get to do, I don't know, maybe that's kind of a gruesome thing to say, but what I love is that we get to kind of walk the family through this journey and prepare them for what's coming next. Mm-hmm. And we can say, this is the current scene that you're watching, and you're not going to believe what could happen next. Now, we don't know when that might happen, but we can use our knowledge and our, knowledge of the research and our clinical expertise to help guide families through that process. And even though we can't say what 6 months or 12 months from now might look like, we can say, I think the next week might look like this. These might be some of the things we're starting to think about and look at and talk about. Mm-hmm.
And I think gruesome is either the word or close to the word that hits something big. We have some subjective studies, some qualitative studies about families that talk about what it was like in those first number of weeks, the acute care time for traumatic brain injury. The title of one of them, in quotes, is "Locked Up in a Cage of Horror," which is what a parent described. And sometimes I feel like either I'm watching a film or we're in it together with them. But that we do know what the next scene could show, and we've been doing this together long enough to say, I bet we just did this. We're preparing for the next phase. The thing you were talking about for an audience here is the Ranchos Amigos scales of recovery in this case, mm-hmm. And one of the better things to Google and what we have families Google is the Ranchos Amigos Family Guide.
Okay,
that describes common phases of recovery. In language, I'll tell you the truth. There's a family guide and there's like a provider guide or like deeper data on it. I use the family guide myself.
Yeah, I agree.
There's reasons to use the provider guide at times, but when you want it to be palatable and you want to describe it,
yeah.
If you go back and reference it, I reference the family guide more than anything else myself still, okay. Because it allows me to level with people.
And I think that, even for people listening who are maybe working with patients in the more chronic stage of brain injury, or for people who have maybe a loved one who is in that more chronic stage of brain injury, so, maybe years after their injury, I still think understanding what that acute recovery phase looks like is so critical. And I love that reference you made to that article, Locked in a Cage of Horrors.
Yeah.
And I think it's really vitally important for people working with families of kids with very severe injuries to know that is what a lot of them experience in those early days.
Yeah.
Because if you haven't been in that ICU room with a family with a kid with a very severe injury, you don't know what that looks like and what that experience was like for them. And so even if, people are listening, they're like, oh, I never would work with somebody in a hospital setting, or, I wasn't familiar with this patient when they were there, I think it's so really important to know what that beginning of that journey really looked like.
Sure. I mean, it's the start point. And even though we don't know what the trajectory is, it's going to influence it to some degree, right? We're talking about kids at large, right? But a 5-year-old is very different than a 16-year-old. So how does this present, or how do you change the way that you approach things? What's different about those two kinds of situations, or as a continuum of aging?
Yeah. That's one of the things that really sets pediatric providers apart from adult providers, is that we are working with kids across that range of development. So those 10 years, between 5 and 15 is going to be very different than the 10 years between 30 and 40, for instance, because there's so much development going on. And as a neuropsychologist, one of the things that I'm thinking about first and foremost, especially with younger kids, is what were they doing developmentally before this injury? Because that can really impact what their recovery is going to look like and what I might be expecting in those early days. But after the injury, one of the things that I'm thinking about is, for those little kids, we're not expecting them to be good at higher level thinking skills. We don't expect those skills to be there yet. So one of the things that's really important is, and I'll tell families this, always keep this early injury in the back of your mind as something that could impact them later in their life when those earlier, those later skills are starting to develop. And I'll make the comparison to families. I think of it as almost like you're building a house, and in typical brain development, you're building a house and you've got a really solid foundation. You've got that solid foundation of those early learning skills and typical brain development, and you can build, kind of story after story after story on that really solid foundation of those early cognitive skills. If those early cognitive skills and that early development has been disrupted by a brain injury, you might kind of have a shaky foundation, and it still might look okay early on. And maybe a couple years after the injury, we don't really notice an impact of that. But when we're starting to build those higher level skills on top of that shaky foundation, that might be when we really see the impact of the brain injury. So it might not be for a few years down the road that we really see the true impact of that.
I think on the early medical side, a lot of it comes back to that first thing about identity, and that we do see this great variability in folks. We have 5-year-olds that act like 12-year-olds. We've got 16-year-olds that act like 12-year-olds, and so age is a big thing, and it does play into outcomes somewhat. That's just data. Is that for the single outcome? Either they have a good one or they don't, right? But it's something at least to consider, especially under the age of 3. That outcomes can be more difficult to achieve. Good outcomes can be more difficult to achieve. But I still think a lot of it comes back to that personal identity thing. Then younger folks will have a different identity, different approach, and different thing we're trying to rehabilitate. In both situations, in basically every kid situation, it ends up being play to some degree, that play and leisure. Let's take us a bit further. Humans need to do that. And so it's probably we accentuate it in the kids that we take care of in the children's hospital, but adults need it just as much, and adults need leisure just as much. But it's not as much of an age thing as it is how they do it based on the age that they are.
Yeah, it seems like a central theme is we're still going to come back to that person, that individual, and then we're going to figure out what that looks like for them, as opposed to maybe some other kinds of data.
Yeah, it's easy to lose humanity during this process and focus on the science. It's really easy, and I think that when you come back to it again, the both patient and family, or patient and caregivers, there's a different trust that's formed when you come back to that humanity.
Yeah. Well, speaking of humanity, so, right, we're thinking about our health and wellness, right? As you talked about at the outset, right, surviving, right? That's key. I've been in that ICU with my kids, and there is a cage of horrors in some sense. And so, okay, so that's a period of time. And as you said, if they're inpatient, at some point, they're going to leave the hospital, if the care is moving in the right direction. And so they get to the outpatient kind of phase, and we're trying to figure out what's the best use of our time and things like that. I'm just curious about what are the domains that people are thinking about for kids? And again, different ages, but you could think about health and wellness. What are other things that families have to contend with?
So one of the things that I have heard from families that has been really powerful, and we've seen this through some of the qualitative research studies that we've done, and then just, through our clinical experience as well, is that when families are in the hospital, they're kind of in this bubble. They have people taking care of them.
Mm-hmm.
Even if they're caring for their child, there's always somebody they can call that can come help them. They have supplies, they have food, they have everything. They might have time off work, they might have childcare for other kids. And when they get home, I think, and this is probably not the best comparison, but a lot of parents can relate to this. It kind of reminds me of when I took my firstborn son, home from the hospital for the first time. Like driving through the neighborhood, it looked the same, but it just felt different, and that's kind of what families describe as they're excited, they can't wait to get home, but everything feels kind of different. And there's no way that we can prepare them for really what that is going to feel like and look like. And I think that a lot of the things they're contending with, and I'll let Nathan kind of speak to kind of the medical piece, a big thing that I help out with is school. And for kids, that is definitely something that is setting them apart from adults is what is school going to look like? How can school support their recovery? And then how can we on the medical side help prepare schools for that? I really like for kids, if they're medically able to get back to in-person school, where they can get that good routine and structure, they can get socialization, they can get cognitive stimulation, all those great things that school can provide. But that can be really challenging to set up and to navigate, especially for families and especially for schools in more rural communities that might not have the same level of resources. So that domain in particular is one that I think a lot about and I'm helping to prepare families and schools for.
So you're doing this return to learn project. So if you're thinking about all that structure that school provides, can I just send them back to school?
Well, that's a great question. And I think that schools would have some thoughts on that.
Mm-hmm.
So, for a lot of kids, even with more mild injuries, school might look a little bit different as they're first going back. And one of the things that we've done at Nationwide Children's and that I'm helping the Brain Injury Association with is creating a more robust return to school plan. So figuring out, is this a kid who's ready to go back? Are they medically cleared to go back? That's kind of the first question. And if not, when might that be? And once we know they are medically cleared to go back, what could that look like? Can they tolerate a full day? Do they need to go back partial days? Do we need to work around therapies? Usually we recommend that if kids have, PT and OT on a Tuesday, they might stay home from school that day because that's going to be pretty tiring. And we also recommend things like pacing, things like modified workload. If a kid has been out of the hospital for a month, I don't want them getting sent home with the workload from the whole month they missed, even if it is a more mild injury, because that can set them up for, increased stress and being overwhelmed. Yeah. So there's a lot of things to really kind of think about. How do we help this kid as they're continuing to recover? And a lot of it comes down to following the kid's lead. We expect after brain injury that kids are going to continue to recover after they leave the hospital. So the level of support that they need day one in school could look very different a month or 2 months down the road. So I like to encourage schools and families to just be really flexible. And if the child is tolerating a longer day or, maybe a more typical workload, I would say go ahead and give that a try. One thing that comes up a lot that I will mention is screen time, because that's a big part of schools now. And again, I think that especially for kids with more mild injuries, if they can tolerate being in front of a screen and they're not having headaches and they're not having eye fatigue and they're not getting irritable, then it's probably okay for them to do typical screen time. If they're getting more fatigued or they're getting headaches, then it might be good to kind of scale that back a little bit. So a lot of it is following the kid's lead, communicating with the family, finding out how they're doing at home, and then checking in with the medical team too.
Oh, I just think it's really nice the way you worded the screen time thing. I think there's historically been some more things about absoluteness, about the no screens and the
Sure.
and The more we get away from absolute and try to find a spectrum of things is really valuable. I just wanted to catch that part.
Yeah, and there was an interesting study, and this is getting to kids with more mild injuries and kind of speaking to your question, Kadar, like, can kids just go back to school with nothing? With the more mild injuries, we used to think that you needed to kind of reduce all activity and put them in a dark room till they started to feel better. And we now know that that's not the case. And there's been some interesting studies that have come out that have shown the sooner that kids with concussions get back to school, the better they do. So even with the more severe injuries, we might want a more robust plan for them to return to school, but we know that school is a good place for kids to be. And that's really what we want to work towards.
Yeah. Well, I mean, the social side, there is some challenge, there's some variability in the day, but also the structure, right? This is what they're used to doing. So it makes a ton of sense. So we've gotten some money from the state that's gone to the Brain Injury Association to start working on this return to learn. So maybe we'll have you back. Once we've solved this problem. Right? And so we were talking a little bit about what are those other domains that families might be thinking about or struggling with. So school being a big one, sure. Anything else that comes to mind?
Yeah, I think it lends that situation of a situation where physicians are leaned upon to help folks parse out priorities. And it comes back to a conversation. One of these things, if you ask people how they feel, they'll tell you if you have trust. And the more you ask, the more you find out, and the more you realize that maybe the approach that you're taking isn't the best one. And I was in Joshua Tree National Park driving around with an orthopedic surgeon of all people. He said to me, this is David Frumberg out of Yale. He said to me, "Do you ever talk to your families about time?" And I said, "We do, but not a lot." And he said, "Well, just go and tell me what you see. Like, tell me what you find." And I went back to practice and sort of asked them about time and time allotment, and the same theme message kept coming back over and over again, which is, we have none. We're double booked for everything. We hardly make it fit. We don't feel efficient with time. We don't even have time to have fun or sleep. And we don't know what to do because we're spending all this time. And where are we spending all this time? We're spending a ton of time in the healthcare setting, and we don't know that all of it is fruitful and helpful. There's a recent article that we put out about that topic. It's more cerebral palsy focused, but the next article will be brain injury, we hope, and we're going to have to write that one too. Same concept, though, and the idea that the more that we talk about time, it helps us differentiate between what's fruitful and what's not. And it all comes back to shared decision making. And it comes back to, what are your goals? If you are in school and physical therapy, occupational therapy, speech therapy, maybe vision therapy, throw it in there, therapeutic recreation, and then medical visits, treatments, all these things that we're doing, is there any time left to feel like you're human, to feel like you have an identity, to feel like you have joy? And who helps to make those decisions? And so the step we're at right now is step one, empower clinicians to ask that question. Do you have time? What do you think is useful from your time? What's working and what's not? Because you don't have to do it all. If he leaves you with nothing, you really don't have to do it all. That's step one. And then step two is, how do we empower researchers to quantify the time cost of a certain benefit? So let's say that there's a therapy program that improves function this quantity in some study. And then you can actually measure it and say, this quantity, and it took you 1,000 hours or whatever the number is.
Yeah.
And it helps people make their own decision about it to say, do we want to give up 1,000 hours for this increment of benefit? So using time as a variable in how people make decisions.
I mean, I think it's incredibly a useful conversation to have. I mean, I like the irony that we're asking clinicians who don't have enough time in these encounters to ask about what patients' time is like. What would you say to a parent who's just starting this journey that probably applies to most of those parents?
As you were talking, this reminded me of a family I had whose child had I think maybe a stroke. And I had done testing with them while they were inpatient. And then I'd seen them for a couple weeks after when they were outpatient. And parents were, both worked full time, and kind of along the lines of what you were saying, kind of thinking about time and how do we prioritize things. And as a neuropsychologist, we're kind of known for writing long reports with lots and lots and lots of recommendations, right? Kind of every possible recommendation. Like if you could do all of these things.
Yeah. Nathan's having a physical race.
Yeah, he is. He's like, no. And this family who I had kind of wrongly assumed to be a family that would want a lot of recommendations, they said, listen, the report was great, but could you just give us the top 3 things that you would do? Like, what are our priorities? And as you were talking, Nathan, I was thinking that would be a great thing for families who are feeling overwhelmed and overburdened to ask, to say, all right, all of this is great, but what are the top priorities? If we could do 3 of these things, what are the 3 things that you think that we should prioritize and spend our time doing? And I think as a clinician, usually we can kind of come up with our top 3. I'd say, yeah, PT, OT, speech, vision therapy, that would be great. But you're telling me that they're having trouble getting around at home. Let's move vision therapy up to the top and work on that right now. And then we can get to these other things. So I feel like that's a really great place to start. And I think that, again, as a clinician, I'm thinking I need to tell them all the things that they could do instead of maybe those top things that they really should be doing. Because if you give too many, then they might end up doing nothing.
Yeah, for sure.
So,
yeah, and in this case, it sounds like everything is maybe the enemy of good.
Yeah.
That everything might be the enemy of success. The thought of doing everything and doing all the things just okay might be worse. That really broad approach versus saying, here are some meaningful goals we'd like to achieve and put our efforts into right now, instead of having 10 projects on the table.
A parent should feel comfortable to advocate for what makes sense for them.
Yes,
absolutely.
please.
Absolutely. And I think we've probably both had the experience, and especially, I think, at least for me, earlier in my career, where a family is telling me, I can't make this work. I can't do this thing that you're telling me I need to do. And it takes a lot of, I think, humility to be able to take that step back and say, okay, you tell me what you can feasibly do, and then let's figure out how we can get to the best outcomes, given maybe the resources or the time that you have. Like, how do we get there together? Because families are going to do what they're able to do. And I want to be able to give them guidance to fit within those constraints.
And it points to an interesting, subtle, call it a red flag, call it something to be aware of in our world, in looking at families that have fewer resources than other families. So commonly single-parent families, or families that have lower income, or transportation restrictions.
Yeah.
That what it appears in the chart is a high no-show rate.
Yeah, right.
And medicine, I'm going to be critical of medicine and medical culture here to say that people will often vilify that. And will, if you get no-showed upon, or if you see high rates, you say, well, they're not trying.
Or someone comes late to an appointment.
Yeah, all those things. And those things that exist are another scope, or another view on that is that they are beyond the resources they have available. And I would suspect in the vast majority of those situations, they want to be doing those things. They want to have the resources to get there, and they don't have them.
Yeah.
And there's a lot of shame in that, especially if you don't have trust, where people can't just say, oh, I can't do that. I have this number of other kids. Like, I can't do that. And for the student, the healthcare student population listening right now, there's a world that vilifies that, and there's a world that empowers those people to do what they can do, and that generates trust with those families to say, we can get a good outcome in this situation. Let's make sure we pick the best stuff. Let's make sure we pick the things that are doable and that will work. And sometimes those are done in your home.
As you said, right? So not every family is going to have the same resources. They're not going to live in the same communities. They're going to be all over the place, right? Ohio is a very varied state as things go. So I guess if I'm looking for a provider and I don't get to come to this world-class institution that is Nationwide Children's Hospital, what am I looking for in a medical team? What are green flags and red flags that I should be thinking about?
This is me speaking from a personal perspective.
Yeah.
That's the one I can give you. That starting with trust is the biggest thing. And I can say, from speaking from my experience, the three of us, all parents of school-age kids, what do? We go, when we need to find a provider, we talk to people about who they trust. So you could blindly just start somewhere, or if you have a semblance of community, some Facebook or whatever the social media thing is, or someone you trust, or someone that you know that trusts someone that you trust, finding somebody that if you feel that if somebody else says, when I go in the room, they listen to me,
Mm-hmm.
I feel like we can get somewhere. It doesn't need to be at a huge institution, big one, small one. They listen to me and they can follow through. They have the resources to do so. And again, being critical of medicine here, sometimes the time is such a limitation in medicine that some providers don't completely follow through or don't follow through on time because there's too much to do.
Yeah.
The communication happens slowly outside of the clinical setting and things like that. But then the other world, I have a ton of colleagues. I'm sitting next to one, and there's a ton of other ones too, who are fantastic and who have a consistent role where people say, I trust this person. That's the same feedback I get every single time with these providers. And so the others trusting somebody is a huge deal, at least from this perspective.
Yeah.
I also think that, in more rural communities, it is going to be hard to find pediatric providers with brain injury expertise. And that is just the reality of, the world that we live in. So I think that families should be prepared to go and have to explain what happened to their child and what their current functioning looks like. And that's something that I've heard from families as they transition from the inpatient to the outpatient setting is they feel like they have to retell their story again. And, that can be traumatic for families, that can be annoying, that can be overwhelming. But I think that can help the provider to understand what their experience has been like. So I don't see that as a red flag for them to have to kind of go through and tell their story. I see a patient's medical records all the time, but it misses that human element of what the family went through. And so I like to be able to have that conversation with a family so I can hear what their experience was like. The other thing is that a caregiver is often the number one expert in their child. They know their child better than anybody else. And I think when you find a provider who recognizes that and welcomes that and has that kind of collaborative, let's work together. How can we problem solve together? I think regardless of the diagnosis, that is going to set you up for success. I love when there's even like a physician that I have that says, well, I don't know the answer to that, but I'm going to find out because I have colleagues that might know the answer. So I'm going to go and talk with them. Or before you came in, I talked with your team at Children's. So I got a better sense of what's going on. Like those to me are all very much green flags. We're all human. We don't know everything. But if somebody builds that trust by acknowledging, I don't know the answer, but I'm going to find it, and I know the people to call or the places to look to find it, to me, that is very reassuring.
Doctors Rosenberg and Koterba, thanks so much for coming to NeuroNights and sharing your wisdom.
Absolutely. It was a pleasure.
It's been great. Thanks.